Okay, now before going any further, what I want to discuss about is the electrophysiology of the heart. How do the waves actually come to be like this? So for this, let's draw out a heart first of all. Okay, this would be the interventricular septum, and then we have the left ventricle. This is the left ventricle, this is the right ventricle. Now the P wave is, as you all know, is atrial contraction, and if you split this P wave in the middle, the first part is the right atrial contribution, and the second one is the left atrial contribution. When the left atrium actually hypertrophies, such as in cases of mitral stenosis, the P wave gets split in the middle. So this is known as a bifid P wave or a P mitral. It looks umbilicated, and this would be the right atrial and this would be the left atrial part. All right, now coming on to the QRS, the first part of the ventricle that gets activated, that gets depolarized first, is the left lower part of the interventricular septum. So right over here, and the wave travels in this direction. Now, one thing that you have to know is that the leads are, like this on the chest wall, and whenever the vector is traveling in the opposite direction, it gives a negative wave. So if the current is traveling towards the lead, it gives a positive deflection. If the current is traveling negative in the opposite direction, it will negative deflection. So the first part that becomes activated is the left lower part of the interventricular septum, and it travels towards the base. This would be the base of the heart, and this over here would be the apex. So it travels from the apex to the base, and it is traveling in the opposite direction of the leads, so it gives a negative deflection. So this is the first wave that you see, the Q wave. Now after this, the depolarization happens from the endocardium towards the epicardium. Now what do you think will happen when a wave is going towards the leads? It'll give a positive deflection. So this is the R component of the QRS complex that we see. Now what happens is when all of the cells of the majority of the ventricle, they become depolarized, there is no current flowing through them. They are at peak. So when they're at peak, the current will drop, the wave will drop back to zero. Okay, because they are all in phase with each other. Then the last part of the ventricle that becomes activated, that becomes depolarized, is the basal part of the ventricles. Okay, so if you ever get a question about this, that which is the last part of the ventricle to get depolarized, is the left posterior basal part of the heart. Okay, so now over here we see that the current or the electricity is traveling in the opposite direction. Now this is a positive current, depolarization, which is traveling in the opposite direction of the leads, so it gives you a negative deflection. Now again, when all of the cells are in phase with each other, it reaches back to the baseline. Okay, it goes back to normal, to zero. All right, now talking about the T wave. T wave, as we all know, it is a left ventricular repolarization event. Now repolarization, it happens from the epicardium to the endocardium. All right, it is going in the opposite direction, but it is a negative wave. Right, the repolarization happens downward, in the downward direction. So one thing that you should memorize is that depolarization is a positive event, and if the depolarization is happening towards the lead, it will give you a positive deflection on the ECG, and if it's happening away from the lead, it will give you a negative deflection. Now repolarization is a negative event, okay, and if the current or the electricity is flowing away from the lead, it'll give you a positive, because a negative going in the opposite direction, two negatives make a positive. Okay, so that's why here are the leads. The electricity is traveling in the opposite direction from the epicardium to the endocardium. It gives a positive wave. So that's basically how the electrophysiology of the heart works. Okay, now that we have that out of the way, I want to talk about left bundle branch blocks and right bundle branch blocks. I don't want to go into too much detail, like I said. Remember this mnemonic, William, Marrow. Okay, so William is the left bundle branch block, Marrow is the right bundle branch block, and you look for a W wave in V1 and an M wave in V5. Okay, for right bundle branch block, you look for an M wave in V1 and a W wave in V5. All right, so let's just look at this ECG strip. Over here, this is V1. Can you locate a W over there? Not really. Over here on V5, we actually see an M wave. Okay, there you have it. There's an M, there's an M. And similarly, sometimes you can see the same changes in V6. So this is how you look for a left bundle branch block. Now, usually with a left bundle branch block, you get left axis deviation. Okay, so let's just look at what the axis would be. Let's just draw a circle over here. And here we have our AVF. Here we have our lead 1. What's the deflection in lead 1? It's positive, so let's just shade the entire thing. It's positive. And well, what about AVF? It's negative. So it would be here. And where do we have our overlap? It's in this region, in this quadrant. This is left axis deviation. Okay, here would have been normal, here would have been right axis deviation. Okay, another method to look at left ventricular hypertrophy or left axis deviation would be to look at leads 1 and 3. How I remember is that left leaves and right reaches. So you look at the QRS complex. Over here it's positive, over here it's negative. So 1 and 3, it's leaving. Okay, it's not reaching together. So this is left axis deviation or left ventricular hypertrophy. Okay, so left leaves. If the QRS was negative in lead 1 and positive in lead 3, it would be reaching towards each other. Okay, so that's right reaches. That would point towards a right axis deviation or a right ventricular hypertrophy. So that's a crude method to do it, but you can always use it. All right, now for this ECG strip, remember that I told you about Marrow. Right bundle branch block. Look for M in V1 and W in V5 or V6. So we can really appreciate the M over here. It's very clear, it's like slapping you in the face. But we cannot really appreciate the W in V5. And you can't always see all of the findings. If you see one, it points you towards that direction. One thing that I want to point out is that these M waves, they're given the name of rabbit ears. Rabbit ears. Now, I don't know, these don't look like a rabbit ear to me. Over here, yeah, maybe, but sometimes, rabbits have droopy ears, so I don't know. That's just what's written in the literature, so I thought you would like to know that. Okay, now tell me what's the problem in this ECG strip. Take your time, go over the rate, rhythm, the axis, go over if it's LVF or LVH, RVH, or LBB, RBB. Just pause the video over here and take your time, and then I want to go through all of those things with you. Okay, so I hope that you have deduced about what are the findings on this ECG strip, because I'm about to show you the answers. So if you have not, just pause it. All right, here we go. So the rate is approximately 60 per minute, and it's regular, and it shows right axis deviation. Now, when you get an ECG and you have successfully found out that it's right axis deviation, what are the causes of right axis deviation? There are multiple causes. One is right ventricular hypertrophy, another is hemiblocks, lung diseases, pulmonary hypertension, and so on and so forth. So over here, I told you one crude method of checking if it's LVH or RVH. Is that right? I'm sorry. Is that right reaches? So over here we see that the negative deflection is bigger than the positive one, and in lead 3 the positive deflection is bigger, so they're reaching towards each other, so right reaches. So yeah, it does point towards right ventricular hypertrophy. But one other finding is, look at the P wave, look at the PR interval, look at the QRS. It's not very straight as it's supposed to be. It's sort of, it's curving towards the R, and the PR interval is almost negligible in V1, V2, even in V5 and V6. So what is this wave? What is this wave called? Now this wave is called a delta wave. A delta wave. So what it causes is that it causes the QRS to lengthen to more than 0.12 seconds, and it shortens the PR interval. The PR interval. All right, now this is a type of an arrhythmia, and it's due to an accessory pathway called the bundle of Kent, but I'm not going to go into that. So that is one other cause of, right axis deviation, WPW, which is Wolff-Parkinson-White syndrome. And do any of you know the treatment for this? If you are telling me that it's class 1A and 3 antiarrhythmics, you're right. All right, one other thing that's that's very evident on the ECG strip are heart blocks. Heart blocks. I don't want to go into excruciating detail. I just want to give you an algorithm so it's easy for you to diagnose it. So what you do is you look at the RR intervals first. You start by looking at the RR intervals, R between two waves. Okay, if it's equal, it's either type 1 or type 3. If it's not equal, it's type 2 heart block. Okay, so now in type 1, all the P waves will equal the QRS. In type 3, the P wave will be more than QRS, because in type 3 it's the complete heart block. The atria and ventricle are contracting independently of each other, and normal atrial rate is more than the ventricle, so it makes sense that the P waves are more than the QRS. In type 1 it's just a lengthening, so P's are equal to the QRS. Now in type 2 you have two types, Mobitz 1 and Mobitz 2. In Mobitz 1, the PR interval fluctuates. It gets lengthened, there's lengthening and more lengthening and more lengthening, and then a QRS is dropped. So the first QRS, let's say, is this much, and then the next QRS will be a little longer, and then eventually a QRS is dropped altogether. So it fluctuates. Okay. In Mobitz 2, there's a fixed PR. So the PR is fixed, and over here also it's fixed, and after this PR wave the QR is dropped. Okay, so that's how you can approach a heart block question. Okay. All right, so let me just summarize as to what we have done so far. We have talked about the electrophysiology of the heart, how the waves are produced. We have talked about how to calculate the rate, the rhythm that you already know, axis, how to differentiate between an LBB and an RBB, and RVH and LVH, the left leaves and right reaches, and how to approach heart blocks. So what I wanted to do is just give you a simple overview about the most common things which are asked. And one thing which is left is MI, and I just want to quickly cover that. Just give you, superficial, a broad picture of what all findings you can find on an ECG related to an MI, and after that we're done. Okay, now before finishing up, I just want to quickly touch on the topic of MI, because no ECG discussion is complete without talking about MI. So we basically have two types of presentations. We have STEMI and NSTEMI. Now, just by the names, you know that this is ST elevation and this is non-ST elevation MI. The leads that you should focus on to look for MI changes is lead 1, 2, 3, AVL, AVF, and AVR. Okay, so these are the enterolateral leads. 2, 3 AVF is for inferior wall, and this is for the right side of the heart. Okay, so the limb leads tell you the vertical direction, vertical movement of the current, and the chest leads tell you about the horizontal movement of the current. Okay, so after you look at the changes in these leads, you can tell if it's an anterior or septal or enterolateral by looking at V1 to V6. All right. Now, let's see. This is our typical ECG. This is the QRS and the T. Now this point here, when it transitioned from the S wave over to the baseline and then over to the T wave, this point over here is known as the J point. J point. This is what you have to look at to look for changes of ST elevation or ST depression. This is the baseline over here. If this J point is above, then we call it an ST elevation. If this J point is below, then we call it non-ST elevation or ST depression. Okay, now let's look at a few examples. Over here in this, we can see that there is ST elevation. This point is above the baseline. This point, the J point, is above the baseline. Over here also it's above the baseline. Similarly in V4, V5, V6 just a little bit. So what type of an MI would this be? We have changes from septal to anterior, and we have just minimal changes in lateral wall. So this is probably an enteroseptal STEMI, ST elevation MI. Okay. Now in this second example, we see that the J point is below the baseline. This is the J point below the baseline. Okay, similarly over here also it's below the baseline. Over here it's below the baseline. So there's a non-ST elevation MI. Now you cannot just look at the ST wave changes and deduce that it's an MI. You have to correlate it with the clinical findings, chest pain, radiation, and you have to take help of biomarkers, CKMBs, troponins. The ECG will not stand out by itself and help you in diagnosis of the patient. You have to correlate it with the other findings, but definitely if the findings are there, it points you in the right direction. All right. I just want to touch upon what are the vessels involved. So in the anterior wall MI, we have the left anterior descending. In lateral wall MI, we have the left circumflex artery. Then anterolateral wall MI, we have the left main coronary artery, and then we have inferior wall MI, in which RCA is involved. Now, inferior wall MI and RCA is one that presents with bradycardia, because what happens is that inferior wall is resting on the diaphragm. So inferior wall MI irritates the diaphragm, and diaphragm irritation causes vagal activation, and vagus causes bradycardia. So in these patients, you actually have to manage them by giving them atropine and fluids. But that's another topic. Most commonly involved are the left-sided arteries, which is left main and left anterior descending. Okay, my aim with this video was to just give you a broad picture so that it helps you diagnose a few conditions, and actually helps you answer questions, when you're taking exams. And ECG it's like probably one of the oldest diagnostic tests that is still alive. A lot of prehistoric tests have been outdated. They're obsolete now. But ECG has, stood the test of time because there isn't anything else that tells you about the electrophysiology and what's going on in the heart as much as an ECG does. And I have, utter respect for Einthoven and all the experiments that he did. It was almost around 120 years ago that he knew that there is some electrical activity in the heart. He just, he had the idea. Although, the measurement tools were not that sensitive at that time, and the wires were not thin enough. They were, everything was very crude, So what he thought, he took quartz, the crystal, he melted the crystal, and he put it on a bow and arrow and shot it across the room. And the thin filament wires that were created as a result, he used those wires to pick up the electrical activity of the heart. It's just mind-boggling and fascinating how these people, got these ideas, and we're still using them to this day. I just find it very amazing. And I have never taken ECG for granted ever since I knew that fact. So I hope this video helped you. If I went a little too fast, please let me know in the comments below. I will try to slow myself down. And if there's any specific topic that you want me to make a short little video on, or cover some topic in the broad picture concept kind of a way, let me know. Thanks. Cheers.